Hi, everyone. Welcome to today's webinar. We are going to get started here right now. Today's webinar is called What is Health Equity and is part of our Mobilizing Pro Health Equity training series. Next slide. So this training series is really open to all, but was designed with the support and to support Having Our Say coalition. And Having Our Say is a statewide coalition comprised of over 30 organizations really looking to raise the voices of communities of color as part of the healthcare policy world and discussions. This training series is designed with a lot of input from Having Our Say, and we're really looking forward to, over the course of the year, learning together and discussing some really foundational tools and knowledge around health equity as it relates to advocacy and policy work. So we invite community-based organizations who are interested in learning more about advocacy, whether from a legislative, budget, administrative perspective, to join and share these webinar series broadly. So today is our very first webinar to kick off this series. In today's webinar titled What is Health Equity, we're going to look at sort of broader key terms around health equity, look at an overarching framework for this work, and then really hear from two incredible advocates who've been doing health equity work for a long time, and who can share from their organization's work and perspectives the work that they're doing to advance equity. And we really wanted to start with this sort of introductory framework webinar, and we're looking forward through the course of all the trainings in the series to dive into specific advocacy topics in more detail and build on today's webinar. So before we get started, I'm going to do some housekeeping. If we could go to the next slide. Today's webinar, you will be in listen-only mode, but we do still want to encourage your comments and questions. So you can take a look at the question chat box that should be on your screen. If you have any questions for the speakers, at any point, just type it in there, and we will be gathering our questions and we can pose it to the speakers during the discussion portion at the end of the webinar. The webinar today is being recorded, so we will share with you the recording probably about a week after today's webinar. So we really invite you to revisit the content yourself and share it with your colleagues who might find it useful. And finally, a quick plug for a quick evaluation survey that will pop up right after the close of the webinar. We really value your feedback and input, which helps us kind of measure our work and also will help us adapt the rest of the webinar series. So please take a moment to fill that out at the end of the webinar. Next slide. So my name is Kirti Kanchinadam. I'm a Policy and Outreach Manager here at CPEN. I'm going to be your moderator for today, and I'm joined by a really fantastic team here at CPEN who's helped develop this webinar series and who's here today to answer your questions and is kind of behind the scenes making sure it goes smoothly. I'm also going to give a shout out to Mihei, whose birthday is today, and will be monitoring your questions, so feel free to maybe send your birthday wishes along with your questions in the chat box. And then next slide. So we're also joined today by some really incredible guests and longstanding partners of CPEN, and we're really looking forward to hearing from them today. I'll do a quick introduction now, and then we'll come back to them to share their work and their stories as well. So first we'll have Dr. Angela Williams, who has over 20 years of executive leadership experience in the state legislature as well as the governor's appointee. Dr. Williams serves as Deputy Director of the California Black Health Network, which is a 501c3 focused on Black health equity and creating the conditions for #Healthy Black People. CBHN's cycle of practice includes annual town hall meetings in 7 cities statewide, advocacy for policy change at the California State Legislature, and a biennial Black Health Agenda convening. So we're really excited to have Angelo here with us today. And next we'll hear from Lee Lowe, who's a California policy advocate at the Southeast Asian Resource Action Center, also known as CIRAC. Lee leads CRAC's advocacy work to address health disparities within the Southeast Asian American community. And Lee expands the policy advocacy capacity of Southeast Asian American communities and organizations serving them by coordinating advocacy campaigns, building coalitions, doing trainings, and so much more. So we're really excited to have both these amazing advocates here as resources and encourage folks to, again, share questions throughout the webinar for any of our speakers today and follow up with any of our speakers with additional questions. So let's kick it off with kind of the big question that we're really here to discuss today. If we could go to the next slide. And really, whether you've been doing this work for many, many years, or if you're newer to it, we thought it was worth starting with this sort of foundational exercise to question what we mean by health equity. It's a term that's really becoming widely used in a lot of different spaces, but I think taking the time to kind of reflect on what it really means for us in our communities and how we define it and embed it into our practice is a great practice to kind of go forth on. So we don't have all that much time today to discuss this pretty big question. And we're not really here to present out all the answers, but in this webinar, we do want to kind of provide some tools for consideration in your own work and to really share some examples from our partners of how health equity is really showing up and embedded into their work. Next slide. So we can get started maybe with a standard definition. This is from the Robert Wood Johnson Foundation and is an interesting report to take a closer look at if you have time later. They define health equity as health equity means that everyone has a fair and just opportunity to be healthier. And if you really take a moment to consider sort of what is implied in this definition, I like to kind of break it down a little bit and think about some of the implications. So first off, I see the word health and not health care. So we're really looking at sort of those broader contexts that impact health. We're looking at physical, mental, oral health status, but also broadly well-being. It also then says that everyone has an opportunity to be healthier. So we're talking about everyone, which really means looking critically at sort of the intersections of our identities in our communities and looking really in our work at maybe the voices that are not at the table and not present to be part of the conversation. And then next I see the words fair and just. And I think this is important to highlight as well because we're looking at not only fairness or equalness, but really justice. And it implies sort of a particular need to look at groups that have maybe been historically excluded or discriminated or erased from our work, and therefore experiencing the most obstacles to achieving health. And then finally, it looks at sort of opportunity to be healthier. And so here there's an implication of not only looking at individual choices and how that impacts health or genetics, but really at whether communities have the conditions and the resources and support that they need to make the best decisions for themselves and live healthy lives. So I think if you really, if you unpack it and kind of sit with this for a second, and it really depends on each of us in our work to imagine what it really means for everyone in our community to have a fair and just opportunity to be healthier. So I think next it's helpful to sort of look at what affects health equity. And two key terms that are used a lot and are distinct, but often get interchanged are the words health inequity and health disparity. So let's unpack those a little bit. Maybe looking at health disparities. Broadly, health disparity refers to the differences in health outcomes or disease prevalence across groups. Here we're looking more at standard differences that you might see across groups that might be tied to genetics or to individual behavior choices, and also might be tied to deeper inequities. And then when we look to the word health inequity, we're really looking at differences that are not just unnecessary or avoidable, but are also really unjust and unfair. We're talking about sort of those differences that are rooted in social injustices that really lead to certain groups or populations experiencing worse health. And here is really where we take into consideration sort of upstream factors, our social conditions, our environmental conditions, and economic factors that impact health. And an example that I found helpful that kind of illustrates this, the two key terms is really looking at, for instance, the fact that male babies are often generally born at heavier birth weight than female babies. And I think that's an example of a disparity. It is a difference in health indicators that we see across a population group. But it's really a difference that we generally expect to see based on kind of genetics or and then on the other hand, an example to look at is we see that babies born to Black women are more likely to die in their first year of life than babies born to white women. And this is a difference in outcomes, and it's true even when you look at women within the same income group. So here we're really looking at a health outcome difference that can be partly attributed to poverty, and then also a growing body of research that really is linking the impact of toxic stress, particularly as a result of racism experienced by Black women in our communities, and linking it with negative health outcomes. So here we're really seeing a difference that is a clear inequity that's really rooted in deep social conditions. So I think examples like this help kind of elicit really the terms that we use and how these are not interchangeable, but are definitely connected. Next slide. So I think this image is also another way to look at the factors that impact health equity. This is a framework from the Bay Area Regional Health Inequities Initiative, or BARHI, and is a common way of sort of visualizing all the factors that impact health. If you look on the right end of the screen, you'll see some of the more core healthcare factors, whether it's around clinical or disease or public health kind of factors. And then as you move to the left, you get more upstream factors. And this framework helps visualize and make the case for why we as advocates and ambassadors to our community really have to work across the spectrum to address all of the areas that impact our community's health. And if you also look at this framework, it makes a case for why as advocates we need to partner with groups who affect change at different points across the spectrum. We can really build power by leveraging those of us who do direct services work, who really understand the day-to-day stories of people's lives, for leveraging communities and their own stories, and then also really partnering with institutions, whether government or health plan or hospitals, who dictate a lot in the world of systems and practices and laws. And I think in many ways, the world of public health and health equity has been really looking at sort of these upstream factors. I know here at CPEN that we do a lot of work on the systems and policy change work, working closely with administrative agencies such as the Department of Healthcare and Human Services, with kind of major healthcare players like health plans and hospital systems, and bodies of power like the legislature to really advance policies and laws that start to chip away at those institutional and social inequities that we see. We also really do believe in the importance of community capacity building, and why we're really committing to doing trainings like these, to do listening sessions across the state, and to working with our coalition partners to really bring as many voices as we can into the work that we're doing. So I think just to close it up here, I think as we all know, really achieving health equity requires action. And we're really talking about removing major entrenched obstacles to health. Some really big ideas like poverty and racism and discrimination that really have resulted in major consequences, whether it's access to good jobs or quality education, just feeling safe in your environment, and all of that impacts our health. And I think we could talk about the various strategies and work that people are doing to work towards advancing equity through policy and systems change, where we can really try to address some of the structural racism and the impact of it, through advocating for investment in communities so that we can really ensure that those social, economic, environmental conditions are really there for all communities, and looking at research and data and how we use those seemingly objective tools to really tell the story of those who are most impacted, and also using them as a tool for holding systems accountable to doing better. And then I think sort of at the crux of all of this is really about building power, and changing the narrative, and really ensuring that we look closely at who gets to tell their story and how that story is being portrayed, and builds power at the end of the day. So I think with that broad overview, I really want to turn it over in a minute here to our speakers, who will give us a much more nuanced look at what these health equity concepts look like in their communities, and how their organizations are really spearheading some great work in ensuring that health equity is kind of advanced in a tangible way. So with that, I'm going to first turn it over to Dr. Angela Williams. And as I said, Angela is the Deputy Director of the California Black Health Network, and which has been a longstanding partner of CPEN, and we're really excited to hear a little bit about the work that you all are doing. Angela, are you off mute?
I'm here. Yeah.
Great. Thank you.
All right. Thank you very much for that introduction. Amazing definitions that I think really set the stage for our conversation today. Thanks to CPEN for including CBHN in this conversation. The California Black Health Network has been around 40 years, and in the last 2 years, since I've been here, and our executive director, Doretha Williams-Flournoy, has been here, we've been focusing on policy. And if you want to understand our mission in a nutshell, it's hashtag Healthy Black People, right? That's our mission. We're sticking to it. And what we mean by healthy Black people is really including everyone, right? This includes families. This includes single Black people, trans Black people, undocumented Black immigrants. It includes children and fathers and mothers. It includes members of the LGBT community. So when we say our mission is hashtag Healthy Black People, what we're trying to do is to be as inclusive as possible within our own community in terms of what the mission is. We look at equity in a particular way, and we have embedded it into our cycle of practice. So next slide, please. So our cycle of practice, what we think first and foremost is an equity measure is what we call hashtag carry the voice, right? The people's voice, particularly for the African American community, has to be first. And what we mean by that is that we go every year to 7 cities, and we continue to expand. We've been doing this for the last 2 years. We go to 7 cities where there are African Americans and large African American communities, and have that fundamental conversation about what Black folks want as it relates to health, healthcare, the social determinants of health. And I really appreciate the definition at the beginning, because that expansive sense of what health is extremely important, because it doesn't just look like insurance, right? It looks like more than insurance. It looks like providers and the workforce. It looks like, where's the hospital in our community? Are there clinics, right? Are there African American physicians, doctors, nurses, aides, internists, And even in communities where there are not African Americans, are there folks there that are trained to be culturally responsive? Are they trained in implicit bias? Do they understand the issues for the African American community? So our process, as it relates to equity, is wedded, right, welded into how we go about doing our work. Now, we start off with town halls in 7 cities, and then as we go through the cities, we talk to different organizations, anchor organizations that want to carry the work along with the people. One of the most important features about the town halls is that you don't have to be affiliated with an organization to participate. And what we mean by participate is we gather qualitative data, again, about issues from, cancer care to maternal and infant health, to issues around Medi-Cal, private insurance. All of that becomes this big stew of issues that organizations then carry on into conversations. And those conversations usually end in our convening, where we have organizations and individuals. The last one we had was in Los Angeles. And then we take that information and we bring it to the legislature. And so we fight for advocacy, or we fight to inform folks and advocate, with that information. We also, turn around and talk to other stakeholders, whether it's at the city level, whether it's at school boards. So it's meant to be an open source document drafted and created by the people to inform folks. These are the issues within the African American community related to health. Next slide, please. Obviously, I think everyone knows this, and this is really just a summary of what I just said. The challenge for African Americans in terms of percent of population is important. So our job is to ensure that the minority voice is heard and heeded in health policy. And our strategy is twofold. We want to carry that direct voice, and also at the same time, we want to build coalitions, because we know we're not alone. We know that folks from the Latinx community and the LGBT community and the Asian Pacific Islander community, we know that there are similar experiences as it relates to race, to class, to gender, to inequality. And so we're looking to build coalitions as a way to make equity a real thing. And when we talk about equity, also we are talking about equality of outcome. It's important to have equality of opportunity, but I think we've learned in the last 30 years that equality of outcome is important. And if we can create coalitions, then those minority issues become majority challenges and majority, kinds of solutions. Next slide, please. So a part of what we mean when we say health equity, it means that Black people need more, require more, deserve more, and when it comes to access to healthcare, to the highest quality healthcare. This is what we're talking about, healthcare. It also means the removal of structural racism, right? Macro and micro abrasions and aggressions as it relates to care delivery, access to insurance, preventative and chronic/emergency care. A major issue that we're taking on this year are incidences of oral cancer, chronic, as it relates to African American men. We're also looking at, when it comes to issues around moving structural racism, we're looking at maternal and infant health from an ACEs paradigm, and also from the paradigm of implicit bias. So again, just to finish it off, health equity, of course, also means representing the entire Black community, including undocumented Black immigrants and the Black LGBTQ community. It means a focus on social determinants, right? So generational wealth, lived experience, both physical and social. And more importantly, the most important piece is when we say health equity, it means that Black lives matter. So Black life matters. Black lives matter, the external things that happen to us, right? And Black life, the internal things that we can do with other groups to basically transform systems to create a better process for the lived experience. Next slide, please. Just 2 more and I'll be done. So last year's fight, it's interesting. This is just a snapshot of the bills that we focused on. And so we looked at universal health care as extremely important, but also our advocacy on SB 974 was to include Black immigrants, undocumented Black immigrants, into the conversation, to build coalitions with Latinx community, with other undocumented groups, so that the face of who is undocumented is clear. We're not talking about one group that can be isolated and say, hey, we should treat these people differently. We're trying to expand the definition by expanding those that are defined. We looked at SB 910, and this banned junk insurance, and our fight, along with Health Access and CPIN and others, was really to focus on resisting what's happening at the executive level in terms of sabotaging the ACA. And then finally, a real nuts and bolts bill, and again, this is just a short list. Our longer list is on our website. We supported SB 1021, and it capped the 30-day supply of prescription drugs to $250. Next slide, please. This year's fight, we've got a laundry list, and we're really pleased to have a great new administration and also great partners in CPIN and Health Access and Black Women for Wellness and BAJI and other organizations that we've been working with. So, you know, we're calling for this directly, right? The end of structural racism and implicit bias in the healthcare system. There was a bill last year by Assemblymember Arambula that attempted to do that, to first get the data and the numbers as it relates to managed care offerings. We're going to push again for that with our partners. Also, a focus on Black women's health, including maternal and infant health. There's $45 million in the budget for trauma screening connected to ACEs, and it's going to be led by the new Surgeon General, Dr. Nadine Burke-Harris. And of course, we were fortunate enough to work with CPIN and get an early audience and have a conversation, which we think will be fundamental. And working with our partners and with the Surgeon General, we think that we can get those dollars for trauma screening. Also, violence is a public health issue, from domestic violence to police brutality. We are enjoining a very important discussion around IVF, or fertility in sickle cell anemia. And as we continue with this, you know, along the session, we'll try to pull it out and talk about it more. But the conversation about IVF is often looked at as one group's problem as opposed to a larger issue, right? For us in the African American community, this generation and previous generations, but this generation of African American women, the most educated, the wealthiest, the most powerful ever. And then once they, you know, rose the ladder, right, broke the glass ceiling, they may want to have a family, but the price of IVF and fertility drugs and therapies actually are out of range for them. Can we do something about that? So we're going to join that discussion. And then finally, overall affordability in the healthcare system. We're going to work on that. We're focused on oral health, social determinants of health. And then finally, just a thing to end on, we're looking at the precedent that was established in a Weber bill from last year, Assemblymember Weber, Dr. Weber, related to the lowest performing subgroup. It's a precedent that we think is important for health. Next slide. This is the last slide. So AB 2635 basically said we're going to change the local control funding form in education to fund the lowest performing subgroup. Now, health funding is different from education funding, but if we can think through the mechanisms related to health and healthcare and think about an equity frame as it relates to those folks that have those chronic conditions in particular communities, whether it's race, class, socioeconomic status, geography, if we can look at that and say, how do we leverage funding so that equity becomes equality of outcomes, that's definitely our mission. And again, this is a large, broad issue. We'll be looking at multiple bills to see what we can do about that. But we're looking forward to it. And again, thank you to CPIN for inviting us to share our thoughts at the California Black Health Network.
Thank you, Angelo, for that great overview. We will do a bunch of Q&A at the very end. So again, if you had some questions, please use the chat feature and share your thoughts and questions. And I want to give our next speaker a chance to do their set of slides. So I will introduce Lee again, who is at the Southeast Asian Resource Action Center and is an amazing advocate here for Southeast Asian communities in California and across the country. Lee?
Hi, everyone. My name is Lee Lo, and I'm with the Southeast Asia Resource Action Center. I am CRAC Policy Associate based here in California. And CRAC is the only national advocacy organization on behalf of Southeast Asian Americans, and that include Hmong, Yuman, Lao, Vietnamese, Khmer, and other ethnic minorities in Southeast Asia as well. And because the largest population of Southeast Asian Americans actually reside in California, CRAC opened a California office about 12 years ago to mobilize our communities across the state. And so a lot of the work that I've been able to do has been a mix of the national work and also how that also impacts the California work here. Next slide, please. And CRAC defines health equity very broadly to acknowledge the necessary economic, political, and environmental circumstances that impact our health holistically. And so it's really broad, and it's ensuring our community can thrive, can live, thrive, and age in care with care and dignity. And a lot of that, it has to do with really respecting how there are many factors that affect our health, our mental health, our spiritual health, and our overall well-being, that health equity kind of has to address all of those different circumstances in order to truly achieve health equity for our community. Next slide. And so CRAC has been really lucky to work with CPIN in the past few years, and I'd like to really commend CPIN for being so intentional about listening to our community, to guide their policy priorities. And so a lot of CRAC's policy priorities and health equity opportunities and priorities this upcoming year are actually sponsored by CPIN, and they closely align with our health equity priorities. And additionally, we are excited about the opportunities in 2019 due to the new governor and his priorities, and what this Surgeon General would be able to really help achieve for our communities as well. And so some of the health priorities and opportunities moving forward is really improving culturally and linguistically competent mental health services, because most of our community members across the state have expressed that a lot of the CVOs who provide culturally and linguistically competent PEI services are where our community members are actually accessing mental health services. However, the stigma around mental health continues to be one of the biggest barriers in actual utilization of clinical mental health services, and many of the counties that have not really truly valued a lot of the work that they've been doing. So along with CPIN's bill to provide greater review of county cultural competence plans and the governor's commitment to prevention and early intervention, funding and investing more in PEI services, we really hope to see major wins for our communities in the upcoming year in 2019. Additionally, Health for All, as many of y'all know, is sponsored by Health Access and California Immigrant Policy Centers, and has continued to be a priority of ours as well, because a lot of our community members are undocumented because of the official close of the Refugee Resettlement Act that did not successfully resettle a lot of the refugees and immigrants that are looking to be resettled. And so because of that, many of them have been able to come over through family immigration policies. However, others have also chosen to overstay their visas and remain here undocumented. And because of that, CRAC supports the Health for All campaign to support eligible undocumented community members have access to full scope Medi-Cal. As many of you all know, Governor Newsom has committed his budget to ensure Health for All for young adults, and we would like to continue pushing the governor to understand how pressing it is to ensure that all undocumented adults have coverage. Additionally, CRAC is also prioritizing improving Medi-Cal quality, because Southeast Asians utilizes Medi-Cal many of them utilizes Medi-Cal as their primary health insurance, and improving the quality of Medi-Cal managed care would essentially lead to improving the health care of Southeast Asian Americans and other communities of color as well. And last year, AB 2225 2275, which was sponsored by CPEN, actually attempted to improve the quality of Medi-Cal by developing a quality assessment of healthcare plans and providing incentives to plans that have shown to reduce disparities. However, that bill was vetoed by Governor Brown because of his commitment to leaving with a strong rainy day fund. And with this new governor and newly appointed Surgeon General, we hope to really improve healthcare for some of our most disadvantaged communities. And so moving forward, these are really a lot of CREAC policy priorities, and a lot of it may echo a lot of what you all may be working on as well. Next slide. And so, because I figured a lot of folks would also be sharing and may have experience with legislative wins, I actually wanted to share a different perspective of policy change that is possible and is impactful as well. So CREAC championed an advocacy campaign along with other community partners to give traditional healers, shamans, access to the hospitals. And because Western medicine believes that illnesses and diseases are a result of the physical body, but traditional healers in the Hmong community believe that they are a result of losing one's spirit. And this difference in healing led many community members to avoid actually utilizing Western healthcare services, and with many individuals being seen for the first time in emergency hospital rooms. And this difference because of this difference and their bad experiences while they were being resettled here with a lot of the health checkups, a lot of them just refused to see an actual doctor in the hospital. And we see that this distrust and this distrust has led to a lot of cost in our communities, whereas they are not getting access to the services that they need. And a prime example of that is captured in the book, The Spirit Catches You and You Fall Down, where the consequences of distrust and miscommunication between a Hmong family and the hospital in Merced led to the paralyzation of this young Hmong girl who was being treated for epilepsy, and the hospital failed to recognize the family's cultural beliefs and healing practices around epilepsy. And the fallout of this case actually prompted many Hmong community leaders and hospitals to search for a common ground of how to meaningfully integrate the two. Next slide. And so because of that, a lot of the efforts to bridge the Western and traditional medicine started in Fresno with FIRM, Fresno Interdenominational Refugee Ministries. Their AD expressed their passion and interest to really increase the education about the Hmong community and also bridge the gap of Western and traditional medicine. And with that, we created the Hmong Health Collaborative of our partners throughout the Central Valley and all the way up to Sacramento as well. And in 2008 and 2009, we advocated to develop solutions between the Hmong community and the major hospitals across the Central Valley. Next slide. The Hmong Health Collaborative held advocacy meetings with stakeholders and medical institutions targeting large hospitals like Mercy Medical Hospital. And eventually, the advocacy efforts led to regional hospitals to embrace the shamans as fundamental to healing and serving the Hmong community. And Mercy Medical Hospital actually adopted a policy change to develop a certification program with Hmong shamans to bridge these gaps and even open their doors to Hmong shamans. And in September 2009, Mercy Medical Hospital officially opened its doors to Hmong shamans. And so this was really an opportunity for us to bridge how we can integrate the different Western and traditional medicine and how to best serve the Hmong community. Next slide. And so Mercy Hospital policy changes formally recognize shamans as traditional healers, granting them the same access as clergy members as well, and approved of 9 different types of ceremonies that could be performed in the hospital, with considerations of sanitary considerations and also noise level disturbance levels as well. And So this was a really big win for our community, and because of that, because of this win, a lot of community members started to really trust Western medicine a lot more and see how their own traditional religious practices could be valued in the Western sphere as well. Next slide. And so, like I said, this is a prime example of how policy change really led to advancing Southeast Asian American healthcare and health equity. And it serves as a model of how health equity can be achieved through involving community members, and especially those who are most impacted, valuing the different and most effective ways to approach and serve our communities by training the Hmong shamans to understand Western medicine, and training the doctors to understand the value and importance of Hmong spiritual healers. And it really led to a lot of demystifying the Western medicine and also gaining the trust of the Hmong community so that they would start utilizing these services instead, a lot more, and a lot earlier in the stages too, so that they're not just being seen in the emergency rooms. And many Hmong elders actually know to this day of their right to a shaman. And that is so important, especially since a lot of times policy changes, but then that information isn't relayed well enough to community members. And so the Hmong Health Collaborative actually did a lot of advocacy within the community and also externally with the hospitals to work with them to better understand what are our needs and also what is most effective in communicating with our community. Next slide. And that actually concludes a lot of my slides. A lot of the things that happened with the advocacy on the shamans was actually even before my time, and it's been fundamental to be able to be someone who grew up during that time and be able to witness the change in the Hmong community's perspective, and being able to benefit from CRAC's advocacy campaign, to be able to really to see my parents utilize these services as well. So that concludes the end of my slides, and I'm more than happy to answer any questions y'all may have about it.
Thank you so much, Lee, and to Dr. Angela Williams as well. Thank you both for those overviews. Some really amazing nuggets in there. Just a reminder to folks, please feel free to send some questions our way through the question feature. They're coming in, so continue to do so, and thank you. And I will kick it off with some of the questions we have here already. Maybe we can start with going back to some of the work that, Angela, you shared around the Black Health Agenda and this year's priorities. And I think both of you really did a great job of articulating some of the real opportunities that are available under this new governor. And I'm wondering if you could share a little bit more about kind of how your anchor orgs and your base really were used to create this Black Health Agenda, and to bring kind of that equity into this policymaking process, and then really what folks on the phone and allies can really do to help uplift the work that's going on.
Absolutely, yeah. Well, 2 years ago, we set off on a really ambitious course. We knew our board gave us direction. They said they want us to get more involved in the policy debate, and they wanted us to inform stakeholders, not simply with the data from reports, which are great, but also from the lived experiences of African Americans. And so when we first set out, it was challenging only in the sense that we did receive a little pushback, from, particular sectors, which again is kind of to be expected, and not really, honestly, it wasn't negative. But let me give you an example. So when we talked to the Black community in California, and we talked to them about Medi-Cal, they said there was a stigma in using the card. and that the under-enrollment of African Americans has more to do with that stigma, which is created by those micro abrasions and aggressions and out-and-out structural racism from the community's point of view. Now, when you talk to researchers at, Pixel University or a think tank, they'll say, well, it looks like African Americans are participating. So we tended to look at the triangulation of that data to be able to wedge in and leverage a space for that community voice. Because a part of what we're saying is it is perfectly normal to say all these things at the same time. Yes, African Americans that are using Medi-Cal like it. African Americans that are using Medi-Cal, some don't like it. And some of it doesn't have to do with the service itself, but the providing of the service. And at the same time, it gave us a hunch, right? Well, maybe the under-enrollment, and, this is what Covered California has been telling us for some time, the under-enrollment of African Americans has something to do with that stigma. So once we rolled that out and got that into conversation, several organizations stepped up and said, "Yeah, I'll take that on. I want to have that conversation as well." And many unaffiliated folks. And so by the time we got to, we went to an ITUB convening, and again, we're carrying the voice of African Americans, in local communities. It was a revelation to that group that that could be something. So what we've learned to do over time is to trust what Black people tell us. And that it doesn't have to be right. Right. What I mean by that is that it doesn't have to be accepted as the norm or as the conventional wisdom. It could be something that everyone says, no, I don't think that's real. We're trying to add in that third stool in this triangulation process of making public policy, and we think that the people's voice, is an extremely important part of that stool. One thing to say about anchor organizations. So the interesting part about the Black Health Agenda is it's an iterative process, right? So we have a finished product from last year, but the product will transform again, by September, right? Because we'll have more input, we'll have more bills. But we're trying to create an open source document that anybody who wants to advocate on behalf of African Americans in California can use. And so our anchor organizations, the appeal to them is us finding the alignment between what's happening at the local level and what is happening at the state level in terms of policy. And so one of the ways we've been able to attract organizations who are for us is being for them. And so those best practices are really important, because sometimes when we come from Sacramento, what of course happens is that people in the community feel like, hey, well, you all have all the answers and you have your agenda. And so, either we fit in or we don't. And what we're saying when we come out and talk to folks and we ask, jump on board with us, is that we're saying, look, our agenda is your agenda. So you tell us what you need, because we're collecting these agenda items over 7 cities, and that collective will, that collective desire, that's going to be our agenda.
Yeah, absolutely. Thank you, Angelo. I think that's helpful to hear in the process and the way that you're framing it, especially as that third stool leg of the stool. I think it's really clear in what you're trying to achieve there. To Lee, we got a couple questions about the work that CIRAC had accomplished with really being able to champion traditional healing practices. In particular, if you are able to speak a little bit more to how really being able to champion those traditional healing practices has encouraged or improved relationships in the community, and maybe encouraged more active participation and engagement as a way of kind of building power, as we're talking about.
Yeah, I'm more than happy to talk about it, especially since so Mercy Hospital created actually certification programs and trained over, I believe, 80 shamans to understand what like certain types of policies, what certain types of ceremonies could be conducted in the hospital, and which ones could not. For example, like sacrificing a chicken is definitely not something that could be done inside the hospital room. Um, However, that training program also included a lot of education about Western medicine, and I think I recall hearing that like that was the first time even a lot of shamans like looked under a microscope and saw all the germs behind certain things, and really educated them on like different types of Western medicine and its value, as well as like it was a dual education of both shamans teaching and talking about how different Hmong communities and Hmong elders like to be approached about certain things, and vice versa about the value and importance of Western medicine. And by utilizing the shamans who are seen as like community leaders and elders in the Hmong community, they use the shamans to then be sort of like the cultural brokers of expressing and explaining how there are value in both the Western medicine and also the traditional healing practices. And because of that, a lot of it, and understanding that the hospitals actually did value the traditional healing practices too, I think it really eased a lot of the anxiety behind that a lot of the Hmong community members had going in initially, because a lot of the healing is more spiritual, that it doesn't actually require a lot of like physical touch or so. And so initially there was a perception that Western medicine was really invasive, and it was really uncomfortable for folks to even seek services and be checked in certain ways. And so utilizing the shamans as cultural brokers, they've been able to really destigmatize a lot of those things and also demystify a lot of the perceptions, and really I think the most important thing was like really gaining the trust of community members to utilize these services. And because of that, like a lot of our community members have now utilized healthcare services a lot more, and really going in and understanding different processes when, for example, they're checking someone's heartbeat, and it's not just like they are intentionally trying to touch their chest or anything like that, but it's with good intentions. And so it's been really able to gain the trust, because these advocacy meetings were an opportunity to both educate community members and also educate the medical hospital policies as well.
Great, thank you, Lee. And just there was someone asking about whether you have any reports or anything written up about this work.
I don't believe we have like reports. I know a few different news outlets reported on them, but then in terms of following up to see what the longer term impact was, I don't believe the recommend.
Okay. Well, I do highly recommend the book that you highlighted. It's a really powerful read as well. Thank you. I wanted to actually going back to Angelo. Really appreciated the way you outlined like this year's fight, and again the key priorities on the agenda. It's a whole host of work, and it's really exciting and powerful. And was wondering if you could speak a little bit more to this idea that you brought up quickly about the equity-based funding, and if you could just share a little bit more about what that work is about and what it looks like and why it's important.
Sure. The trouble with equity, of course, is that it's not equality, right? And equity implies that some communities need more. And on the road, I think, at least how I conceptualize it, on the road to equality, equity is essential. So here's the interesting part. Now, in education, we had, in the 90s, categoricals, right, where they would say, here's a particular group, and we're going to make sure that we put in, I don't know, $500,000 for particular students with particular challenges, and there'd be a program, and it would roll out. And so the number and list of categoricals in education funding just became, tremendous. Also, of course, we know because of Prop 98, there was a 40% budget set aside, so it was that, and the categoricals. And so, sooner or later, the conversation about education funding came to a crescendo, and Governor Brown, along with Mike Kirst, right, put together the local control funding formula. Now, LCFF, when it first started, didn't include African American students by name. It did include students in foster care or low-income students. That was good, but it wasn't equity. And so when Assemblymember Weber presented the bill that basically said, look, this funding system should be organized from an equity base. That means the lowest performing subgroup should be funded more. Well, part of what she was saying was right now, this equity funding will go to African Americans. But what about the next group up, right? The idea is it's that old tired cliche, right? Rising tides lift all boats. But in this case, from an equity point of view, the tired cliche actually becomes a strategy. If the idea has to be to eliminate the kind of inequities that produce outcomes, right, related to infant mortality and also, shortened lifespan, right? I mean, at the end of the day, we have to do something clear, immediate, and structurally sound. And so this equity framework in education basically says, without naming African Americans, it says the lowest performing subgroup will in fact receive the majority of the funding. Because the belief is that sooner or later, if African American students get more funding, more help, and equitably based education, they in fact will no longer make up the majority of the achievement gap. I think we've got to think about what that means in terms of health. It won't mean the same things. It won't look like the same. It won't look the same way. I'll quote the governor, right? One of his first conversations about health when he came in the door is he said, right now we're paying for sick care, not health care. And so thinking clearly about an equity-based framework. And again, this is the thing that one of the things that we enjoy doing the most. We don't have all the answers. We just have a good question, and we want to join the conversation. So that's where we think the conversation should be, because we're talking about structural change and not just nibbling at the edges.
Thank you so much for that. I appreciate that. And just two more real quick. For Lee, looking at CIRAC's health agenda for 2019, one thing I wanted to ask a little bit about, if you could speak about, is the work around Health for All, and in particular, the work that CIRAC hopes to do to really uplift the need and urgency for Health for All adults, regardless of age, and particularly the elders and seniors in our communities. Could you speak to that a little bit, Lee?
Yeah, I think with a lot of these conversations, we're coming to find out that even within our community, there isn't a lot of understanding about our undocumented Southeast Asian American community too. So I think a lot of our work that we are foreseeing to do is really doing a lot of community education on our own community to understand that undocumented Southeast Asians exist and that they are that they require additional support and require us to be doing advocacy on as well as also making sure that they are not left out of the narrative for Health for All, because as you all mentioned before, there's tons of undocumented populations and communities, and we want to make sure that it's something that we are standing in solidarity together to work on this. And so a lot of our advocacy will really be to make sure that Southeast Asian Americans are also included, and that our community members are showing up for this fight, and that we are educating internally within our communities about the need and the existence of it within our communities. And so we're still having a hard time because it's something that just folks are just so unwilling to talk about, unwilling to share, and so it really requires deep-seated trust with community-based organizations, and whether they feel comfortable sharing even with us about who they have been able to come across and who are impacted and who would be able to really speak to these type of experiences too.
Thank you. And I have a ton more questions for both of you, and I will definitely be taking this conversation offline. Unfortunately, we're out of time for today. But I want to thank both of you for sharing a little bit about your organizations and your community's work and the frameworks and values that you're really bringing to this work that you're doing. I think that this discussion today really, highlighted the importance of community voices, of building power, of really looking broadly at how we push equity forward. And I think both of you are really great models to incorporate and learn from. So thank you both. I'm going to encourage our listeners and our partners to reach out to you. I've included your email addresses. So hopefully for folks who are interested in learning more about how you can engage with these priorities this year, please reach out to Lee and to Angelo and to our team at CPEN, and we're happy to connect folks. We're right at the end of our webinar for today, so just another plug to please do the evaluation when it pops up when you exit out of here. And please join us for the rest of the series where we kind of dive into different strategies, whether legislative advocacy or doing media and narrative change work, and can continue to learn together. So that's it for today, and thank you all for joining us.
Thank you.
Thank you.
Thank you.